Well, good afternoon, everyone. This is Steve Conley, Executive Director of the American School Health Association. We're delighted to have you with us for a special seminar with some special guests. The seminar today is sponsored by the Mental Health section of the American School Health Association. And our special guests are researchers and teachers at East Tennessee State University. I'd like to make just a few housekeeping announcements to answer some of the questions that we generally receive and to set the stage for today's webinar. We generally, folks will ask, can I get credit for this event? And we actually have a broader array of credit, particularly if you're from Maryland, you're a licensed social worker or a licensed psychologist. You can get credit from the state of Maryland, the Board of Licensure for both professions. In addition, ASHA is a CHES provider, CHES credits, and those are provided to anyone seeking that type of certification as a health education specialist. Once we finish the webinar, you will receive an email which tells you how to go to a SurveyMonkey evaluation. Once you've completed the evaluation, it gives you instructions on getting your credits at the bottom. So we really hope that you'll take the step and give that many more evaluations as well. This specific webinar began, and it's one of a series of two, when Dr. Cunningham of University of Maryland was at the time the chair of our mental health section, and then she passes that off to Amanda McIntyre at the conference in October. But I asked Dr. Cunningham, what can we do to present to school folks and our members ways to help related to the adolescent suicide epidemic in this country? Well, things do morph, things do develop, and so we wound up with finding three great researchers located down in Johnson City, Tennessee, with Dana's help. And we identified another approach looking at It's Not Your Father's Shrink, new developments in children's mental health service delivery. So that's what you've come to see or hear and listen and be a part of. When we finish this webinar, this will be posted on the ASHA webpage, which is easy to find. It's ashaweb.org. And the same will be true for PowerPoint and presentation pieces that you experience today. You will be allowed to ask questions. We ask that you type those in directly on your screen. Those will come into the office, and we'll take a look and we should have plenty of time for the presenters to make those answers, and those questions can continue from the moment that we open it up, and we're real tickled to receive questions. The webinar today is sponsored by one of our partners. We're really happy that the Health Information Network of the National Education Association is sponsoring this event, and they're a proud partner of ours. They'll also be joining us at our conference in October in San Antonio. The Health Information Network helps to improve the quality of the environment in schools by addressing problems of mold, poor air quality, and other unhealthy conditions. They educate NEA members about health problems like arthritis, diabetes, communicable diseases such as flu and stomach bugs, heart disease, and others. They work to bring healthy food to children in school, and they help kids stay safer online. One last bullet is to provide school professionals with resources and tools to help them deal with nature-caused and man-made emergencies. So thank you again to Nora Howley and the shop over at NEA for supporting this webinar and for supporting the conference. To point out to you, about 600 professionals will come together at the annual ASHA conference this year in San Antonio, entitled Making Connections, the People, Passion, and Promise of School Health. One of the great things about our conference is the networking ability in addition to the state-of-the-art workshops and presentations in many areas of school health. If you haven't registered or you so far haven't planned to come, again, go to the ashaweb.org webpage, take a look at the list of presentations. Just know that the networking in the hallways is almost as good as some of the sessions, but you will be, I think, very pleased to be part of the annual American School Health Association conference. At this point, I want to turn to, I can point out, that's fine, we'll turn to Dr. Cunningham and Dr. Sylvia McCree-Huntley, who are part of the section of mental health for the American School Health. And I believe it's Sylvia is going to give us a little information on the section. Sylvia, I'll turn to you.
All right, thank you, Steve, and good afternoon, everyone. Again, I want to thank you for joining this wonderful webinar. I would like to take a couple of minutes to share with you and give you a flavor of the ASHA mental health section. And if you're on your computer, you will be able to see the mission, the benefits, and some of the outreach that we are doing. The mission and vision of ASHA mental health section is to advocate for and promote mental health services and support in schools in order to improve the health and academic outcomes for youth. We encourage you to become a member and partner with us. We are working on various issues related to school health and have developed and co-developed, along with other sections, several resolutions related to mental health and youth, such as suicide prevention and intervention, reduce bullying in schools, etc. Again, please visit the American School Health Association website at www.ashaweb.org and click on membership, click on section, and select the mental health section. Thank you so much again for joining us for this webinar.
Thank you very much, Sylvia. And I would like to present our special guest and presenters today. And my understanding is it's going to be a tag team match. You're going to hear from three young professionals who will be bouncing around the microphone. I want to point out first Dr. Stacy Williams, who's an associate professor of psychology at East Tennessee State University, one of my alma maters, I will add. She received her PhD in social psychology at Kent State, and she completed a 2-year postdoctoral research fellowship at the Institute for Social Research at the University of Michigan. Research interests include stigma and identity, translating basic research into those areas to serve those seeking and clinical outcomes. Recently, she's drawn to understanding if stigma can be reduced in the context of self-compassion and innovative strategies for treatment delivery. She's an active member of the Society for Psychological Study of Social Issues. In addition, with Stacy, we have Dr. Jody Palaha. She's an associate professor of psychology also at ETSU. She has a long history of clinical work and training graduate students in rural primary care and school settings. Her primary interest is in translating evidence-based mental health interventions to children where they are typically found, in homes, schools, and elsewhere in the community, such as primary care. She's also very interested in how technology can enhance service delivery and how the method of getting mental health services to children can decrease barriers to care such as stigma, travel, and cost. And last but certainly not least is Sherry Chandler will be with us. Sherry has her BS in psychology from East Tennessee State. She's currently a doctoral candidate at East Tennessee State as well. She's concentrating in experimental psychology with a focus on translational science. Her areas of research interest in translational research and include self-compassion, rejection sensitivity in the context of stigma. Sherry is an active member of the Graduate Student Association in Psychology, the American Psychological Association, graduate student member, and the Society for the Psychological Study of Social Issues, graduate student members. We're in very good hands, and we're very delighted to turn next to Dr. Stacy Wilson. Excuse me, Stacy Williams, I apologize.
Thank you, Steve, and thank you for having us and organizing this session, and to everyone who's been helpful in the process. We're delighted to be here and talking with you all today, and look forward to a discussion later on in our time together. So this is our general talk, but if we go to the next slide, we'll see that we have a specific agenda, and let's just take a minute to go over it so we're all in the know about what to expect. So you've heard a little bit about us, and we'd like to find a bit out about you, but then move on to basically the overview of our goals for the webinar. We have 3 main goals, and within that discussion, we're going to tell you about an NIMH-funded research study that we have recently conducted, and then we're going to talk about some innovations that we think could move forward the idea of providing access to mental health services for kids. And then, of course, we would like to hear from you all, and if you have discussion questions for us, we look forward to hearing what those are and are happy to address any questions that you might have. Next slide, please. So about us, we, as you know, are faculty and graduate students at ETSU, East Tennessee State University, and we are located in the kind of northeast section, the most northeast you can get really of Tennessee, and this area is fairly rural and mountainous, and that contributes somewhat to the access to services that that children have for their mental health care. So we are here today because we care about children's mental health and access to services, and we're concerned about the overall limited access, especially in rural Appalachia, but in other locations as well. So we're here to speak with you about this issue, and we have some very specific goals outlined. At this point, I'm going to ask the other co-presenters, is there anything else that you would like to add as we get started here?
That sounds good.
Great. So to get us started then, we would love to know a little bit about you. And so this is a question that you can answer simply by clicking one of the following. Let us know who you are. If you can pick the one that most closely matches to who you are. This will give us a chance to get to know the composition of the audience, and you'll also get to know who your other attenders as well. So it looks like that 73% of you are healthcare providers of some description, 20% social worker or psychologist, and 7% teacher. So as of right now, we don't have any of the parent category or other caregiver to the child. So it looks like we're all professionals interested in children's mental health services. And so welcome, all of you. We have one additional question for you as you think about telling us about yourself. Where are you in terms of your profession? Are you working in the school system, in a primary care setting, mental health setting, or some other setting? The overwhelming majority appear to be in a school setting, with mental health setting and other setting being the next most frequent. So no primary care health professionals today, but largely all of you are in schools or mental health scenarios. So welcome again, and appreciate you answering these questions, as I think they will allow us to perhaps tailor some of our question and answer period at the end of our session today. Next slide, please. So we have 3 main goals of this webinar today. The first is to understand to service seeking among parents of children with psychosocial concerns. So unlike adults who might have a psychosocial concern and can easily decide whether or not to seek treatment, children rely on the parents to decide that. And so we're trying to understand the barriers to that service seeking. We also want to understand, and here's our second goal, the parents' preferences for services in a variety of settings. So are parents wanting services in particular settings over others? And finally, to discuss innovative strategies for service provision. Are there ways that we can provide services in new ways and then reduce barriers to service seeking for parents? So we're going to talk about these three goals today, and that leads us to our third poll question. And just to get us started thinking about barriers, take a look at some of the barriers listed here and decide which of these you think is the most common reason parents do not seek services for their children's psychosocial concerns. Okay, so to the poll, 44% of you indicate that parents might be afraid that their child would be labeled by the system. So whether it's a teacher or a doctor or some other system in place. Lack of money would be the next most common. Insurance, lack thereof, and the child refusing to go. So the most common there is fear of being labeled. So we will be talking about these barriers in particular, and that's why we asked you about them, but we also have a host of other ones that we'll be covering as well. So we'll come back to this idea. So with our research, we examined a wide range of barriers, and we'll be able to see if, in fact, those were the top reported ones. So I'm going to turn this over now to Sherry, who will be going into more details about barriers to service seeking.
Right. Hi, everyone. First, we're going to go over, we're going to talk about some of the barriers to service seeking that are commonly reported. And as I go through these, you might want to keep in mind whether or not the literature is consistent with the barriers that you thought were important. Common barriers that have been reported through the literature are structural, attitudinal, and family contextual factors. I will go over these and give examples of each. Next slide, please. All right, structural barriers can be fairly straightforward. And these are logistical concerns, such as limited transportation options, and that may include unreliable vehicles or no money for gas. Scheduling conflicts, it may be difficult to find a time for a employee considering work and school. They may have limited resources in terms of babysitters or child care for their other children in the home, or they may have other family obligations they need to tend to. A lack of insurance coverage could result in an inability to pay for services. Or there could be a lack of available services that offer evidence-based treatment. In addition, services that are available may have wait lists. In our area, it can be up to 8 weeks. Or the available services may require a long driving distance, which would go back to whether or not they have reliable transportation, gas, and flexibility in their schedule. These are some examples of structural barriers. It may not be a complete list, but overcoming these difficulties is often the most salient obstacle for parents. Right? Attitudinal barriers include parents' perception of the problem and how to deal with it. Parents may be in denial of the existence or severity of their child's mental health problems or assume that they can take care of it without treatment. They may have negative attitudes towards mental health services or have had a negative experience with professionals, resulting in a lack of perceived usefulness of services and mistrust of providers. The last attitudinal barrier I'm going to talk about is stigma. Parents don't want their child to be labeled because when children are labeled, it can carry negative implications in and outside of school. There are myths about mental health symptoms such as lack of willpower, bad parenting, or that the individual is damaged, and these misconceptions of mental health symptoms can be attributed to the child, and this can happen with the school's peers or among professionals. It can alter interactions that the child has within the school system among professionals and other children. When children learn of a classmate's stigmatizing condition, it may result in harsh or hostile treatment such as bullying or ostracism. Parents often anticipate negative attitudes from the community as well. Additionally, they may be concerned with how long their child will carry the label. Parents might also feel stigma from the mental health care provider when their concerns are dismissed. These type of events may make the parent feel that the presence and treatment of mental health problems is a weakness. Okay, next slide, please. Okay, finally, the family contextual factors are not actual barriers, but characteristics that have been shown to influence parents' perception of barriers. These include various life events and situations, such as parental psychopathology, low quality of life, divorce, and other parental stress. These characteristics have been shown to be associated with perceiving more barriers to care. Because parents may already be overloaded with concerns, any addition is pulling from already limited resources, making it a larger obstacle than if it were a single concern.
Next slide, please. Concerns. And we were really interested in the barriers to service seeking, including stigma, but also a wide range of barriers. So what we did was we recruited parents from rural Appalachia, and we had parents representing a couple of different states and multiple counties, and we ended up with 335 parents of children aged 4 to 16. Parents that completed the entire study, but we have some information on a lot more parents. So some of the data study. And so in thinking about those 330 that we had the chance to interact with, we find here the parents, the average age of the child was about 9 years old and was largely male, but also about 42% female children. In terms of mother, father characteristics, family income was about $35,000 per year, and mostly mothers. There were very few fathers, about 8% of fathers who participated in the study. When people indicated needed, but it was also a range of other types of people. But mostly here it was mothers. And so on the next slide, that patient information. So considering mother education, you can see that this sample was fairly well educated. So only 10 or 11% indicated less than a high school education. We had between 10 and 15% with college degree or post-college degree. So fairly educated sample. And also, as you can see, predominantly a white sample. We have predominantly white in terms of race, ethnicity, in this particular region of the country research study. Slide, please. So in addition to these personal characteristics, we also were wanting to get at how much of a service-seeking sample did we collect, barriers, and ultimately whether these barriers served as prohibiting factor in service-seeking. So we wanted to know, did parents seek previous support or help for their children? And as you can see here, we asked these very specific 3 questions. Had the parents ever talked to a counselor about the child's behavior? And in which case, about 65% of the parents had. The second question, to your doctor about the child's behavior, or the child's doctor rather, and nearly all of the sample did. So 87%, that is the strong majority of parents. And then finally, almost all of the parents had indicated knowing someone else who had received mental health services. So taken together, this is telling me that mostly this is a service-seeking sample already. So let's consider that when it comes to our results of the study as well. Parents just seeking services for their children. And these are a list of possible barriers that parents had to respond to indicate, are these actual barriers for you? So we put them in order of frequency, and as you can see, the most frequently reported was structural barrier that Sherry was indicating earlier. Almost half of the sample indicated that. And we saw that it was a fairly well-educated sample, and for the most part had an average income. Barrier indicated was the parents would be afraid the child might be labeled by the system. So whether it's labeled by a teacher or in the mental health care system or healthcare system, whatever system, the fear is there about a label, and we'll get to talking about that in a little bit. But other things, having insurance to pay, the child would refuse to go, available appointment times were not convenient, and then finally afraid of what my friends would think. So really, if you look at these, they do capture those barriers that are in particular emerging as most frequent. Another other type of barrier that we assessed was for possible reasons that parents can't seek or are unwilling to seek mental health service. We see stigma, this construct, most commonly reported way. I can use some examples of what self-stigma might like. So seeking service, by contrast, the public stigma involves unfairly look down on me, add things about me, treat me with less respect, avoid me, and label my child at school. So it's really this distinction between how do I think about myself and how do I think others either think about me or treat me. And so the numbers that you see inside of the circle in the middle of the screen, the average rates of stigma is what those numbers represent. We asked parents to indicate along a scale up to 6 the frequency or extent of their stigma perceptions. So if you think about 3 being the mid scale, this actually is a fairly low level of stigma reported. So I wanted to point that out because we often think that parents are perceiving a lot of stigma when in fact these findings are indicating, well, maybe it's not quite as much as we think per se, but more whether the stigma is serving as a barrier. So is it actually preventing parents from seeking services? So that is where we went next. Next slide, please. So the second goal then was their children. In other words, we asked parents, would you be willing to seek services for your child's psychosocial concerns from a psychologist? And where would you be willing to seek those services? So really thinking about the location as being one way to tap an innovative strategy for service seeking, we wanted to know, what are parents thinking? Are they willing to actually seek these services in these locations? So the next slide, please, will tell us a little bit about what parents indicated in our study. And again, this is the 335 parents. So this was along a scale of 0 to 6. So 6 meaning that they were the most willing to seek the service in this location. And as you can see, just by eyeballing these numbers, that they're fairly high, that regardless of location, parents are fairly willing to seek services in these locations, whether it's a private office building or the child's doctor's office, a behavioral health center, the school, the church. The least frequently reported in terms of willingness was two-way video conferencing, but even one was fairly well reported. And we admit we did not describe what this two-way video conferencing would actually entail, so we also think that parents might have been unaware of what that process would entail. So nevertheless, these findings are showing us that overall, parents are fairly willing to seek services for their kids. So that's a little bit contrary to some of the findings so far in the other research. But again, this isn't getting at that question of most interest, which is, are the barriers that parents are reporting, are they actually prohibiting their service seeking? And so moving on to the next slide, we're going to show that interplay between those two ideas. Actually, could you go to the next slide, please? So this figure depicts exactly what I just mentioned, in that we're really interested in identify the barriers that are linked with unwillingness to seek services, then those might be areas to address for innovative strategies at service seeking. Next slide, please. The various barriers and parents willingness to seek services in the location such that as you experience more of the barrier, you are less willing to seek mental health services for your kids in that particular area or location. So row of data is indicating that if parents believe they can handle it on their own, they're less willing to seek an doctor's office or believe of significant relationship. Maybe we can tap
Stacy, if I could just interrupt you for one quick second.
Yes.
We had one question, which was, wondering about the rate of willingness to seek services for psychologists. And I want to just clarify that this questionnaire asked responders whether they were willing to seek services with a psychologist in each of these settings. So it actually said psychologist, counselor, or maybe other mental health professional. We put a few different descriptors on there because we knew that there were some different attitudes towards psychologists versus counselors versus therapists, and we didn't want that to play in. So this was asking about basically seeking mental health services from a variety of professionals across these different settings. And the private office and behavioral health center represent the traditional practice settings, where school, church, doctor's offices, and technology-based services represent kind of innovative settings. So we're trying to see if there were some differences in willingness, and then certainly whether barriers played out in different ways across those settings.
Thanks for clarifying that. Next slide, please.
All right, at this point, we may turn back to the literature to see how these barriers have been addressed or suggestions on how to address them. So our third goal is to discuss some innovative strategies for helping parents overcome barriers to seeking care and ultimately obtaining the mental health care they need for their child. And we'll address these strategies by type, even though many overlap. For instance, one strategy may address multiple structural and attitudinal barriers. All right, on the next slide, I'll start with the strategies to address some of the structural barriers. The integration of services can reduce transportation problems and scheduling conflicts. An referral. Also, when being introduced as a behavioral health consultant, negative attitudes towards mental health care may be averted. The telehealth approach can bring mental health care to those in areas that lack available services, such as where we are located in rural or mountainous regions where the closest available service may be an hour or more away. In this situation, therapy is delivered through video conferencing that may be set up at the primary care provider's office and is comparable to therapy delivered in person. Next, I'm going to talk about helping parents overcome attitudinal barriers to seeking mental health care for their children. Research has shown that when parents' preferences for treatment are met, they are more likely to utilize services. And because parents may not have education in this area, these expectations of treatment may be unrealistic or ineffective. So when parents are informed, they're better equipped to make treatment decisions and expectations that the provider is able to meet. Division 53 of the APA, the Society for Clinical Child and Adolescent Psychology, sponsors a website devoted to information on mental health care and evidence-based treatment. EffectiveChildTherapy.com is designed for public and professional use. For parents, it explains what evidence-based treatment is and provides information on child and adolescent mental health symptoms and treatment options. Under the Professionals and Educators tab, you will find evidence-based treatment for specific disorders, as well as treatment training workshops for continuing education credit. Another strategy that is designed to both inform parents and keep them part of the treatment team is practicing evidence-based thinking. Mental health care professionals can sometimes speak in esoteric terms. Instead, speak to parents in terms that they will understand. Also, use a combination of evidence-based treatment, clinical expertise, and parental preferences during treatment. This strategy is useful because it addresses parental preferences by making them part of the treatment team while informing them on mental health issues and treatments, and using personal clinical expertise of the provider. On the next slide, there are other ways to address attitudinal barriers to service seeking, and these include provocative ways to combat stigma. Acceptance and commitment therapy, or ACT, has been shown to reduce stigmatizing attitudes and feelings of self-stigma through mindfulness and addressing experiential avoidance. Mindfulness can help individuals be attentive and aware of the situation surrounding the mental health concern and the mental health issue itself to reduce perceived stigma or better handle stigma they are facing or may face. Similarly, ACT targets experiential avoidant behaviors. Mental illness, and bringingchangeTominds.org. These sources offer more information on mental illnesses and a community setting that facilitates involvement with others sensitive to the issues. National Alliance on Mental Illness has local chapters for regional support, and Bring Change to Mind is an anti-stigma campaign founded by Glenn Close. This provides support through an online community and offers awareness-raising opportunities such as their national walk to raise awareness. And these resources are designed to better equip parents and professionals with information to be a better advocate for the child. All right, next slide.
At this point, we'd like to turn it over to Jody.
I'm here. This is Jody Palaha, and I'm pleased to be here and have a chance to speak this last part of the webinar, and then certainly if Dr. Williams or Sherry Chandler have additional thoughts, they can chime in. And I'm sort of trying to monitor questions that might come in as I'm speaking, and so I'll do my best to get to questions you may type as I'm going. We introduced ourselves as faculty and as academics and as researchers, but I think it's important for me to mention that the bulk of my career was spent in rural primary care and school settings, trying to innovate the way that mental health services are delivered. In my position here at ETSU, I serve a more traditional academic role, but I still spend about 40 to 50% of my week's time in rural sites. Yesterday, for example, I was in Pennington Gap, Virginia, which is in a very underserved, very low health indicator county in southwest rural Virginia, helping to integrate mental health providers into a federally qualified health center there. We also have relationships with school health systems and mobile units and other kind of different ways of sort of building mental health care into health care, and that's sort of a big piece of what I do. I'm very interested in the research and how science can help bring along better services for children, but I'm also very interested in building workforce and trying to get services out there kind of in the boots on the ground kind of way. So that's a little bit more about me to maybe provide a little bit more context. But what I'm just going to talk very loosely about are how our field is disseminating treatments in ways that might make them different than what we've done in the past, and I'm also going to talk about the way we've tried to explore different settings and innovation and how our settings are engaged. And then finally, a little bit about technology as well. You can forward to the next slide. So for a very long time, the way that psychology viewed its science was this bench-to-bedside idea. And we had basic researchers examining, where does psychopathology come from and why are some people different than others, and how can we classify and diagnose and evaluate mental health concerns or deviations from typical or the whole range of expressions of a certain problem behavior. And then if you think about that as a bridge, those basic researchers maybe were coming from the left-hand side. We had this other group of people taking that basic knowledge, and they were developing treatments. Mostly this is the field of clinical psychology, which I'm a clinical psychologist, belong to that group. And over the last 20 years, we've developed this fair armamentarium of evidence-based treatments. And a couple slides prior, Sherry showed you the www.effectivechildtherapy.com website. That's a great one, and there are a few others that now show here are the evidence-based treatments for working with children, and these are the things that work. And we thought that our bridge was perfect because we had this basic science, and the basic science was informing the development of the treatments, and that should be all that we need to do. Next slide. So that's what we thought we had, and it turns out this is what we really had. We had the basic science and we had the treatments, but the treatments weren't getting to the other side. They weren't being delivered in real-world settings. Not only are evidence-based treatments not being delivered, so the people that do get treatment are not getting evidence-based treatments, but in fact, people aren't really getting the treatments. Next page, or next slide. We're really not touching the bulk of the population that we have the capacity to affect. And so we're sort of designing this new bridge now in clinical psychology and other fields within psychology. Even I've seen publications from social work and other fields that are clinical fields, that are people that are out there in the real world getting interested in this idea of dissemination and implementation science. And so the old bridge is still there. We have basic research on the far left, and as you're driving across, you get the basic ideas and you use them to employ effectiveness and efficacy studies. What types of treatments work with kids, and then what you need to do is figure out how do we adapt these so that they work in the real world setting. How can we transport them? That last step, that last bridge piece is all about getting them to the people that need them. And this is a whole new field of science that was not taught when I was in graduate school 15 years ago. It might have been longer than that. Okay. Called Dissemination and Implementation Science. Next slide. I'm going to talk a little bit more about D&I science as we go forward. Some of the hallmarks of this new approach to research is, first of all, really thinking about how do we get patient, student, parent, and thinking about them more as consumers. How do we get their input? These are the people that are supposedly going to buy or not buy the treatments that we're promoting. And to this point, we haven't used their input much at all. We've really just developed the treatments based upon what the basic science says, and the basic science has really not been about preferences or patterns or habits or interests that consumers might have. So this whole new field of dissemination and implementation science is really sort of rallying around this a bunch of different methods, one of them being community-based participatory research, in which people in the community are part of the research ideas, the design, the science. They come up with the questions, they come up with a research method, and they are an integral part of the development of the treatment itself, how the treatment gets tweaked for their community and how it's studied within their community. To some extent you may be thinking, well, I'm a practitioner. I know that a lot of you are providers that work in schools. You may not be thinking much about research, but really where this is going is that people like you are needed because you have that ground view, that on-the-ground view of what's happening. And so increasingly kind of ivory tower research is being sort of not as prioritized as research that's happening out where people are, where real-world things are happening, and where we can get stakeholder input. The other thing that's happening is interdisciplinary teams. And certainly if you're a healthcare provider working in a school, you appreciate the value of you know, something like people with education backgrounds and then healthcare backgrounds working together, possibly of integrated mental health as well. And you see how important it is to bring those different knowledge bases together. It's important for kids' care, but it's also important for developing innovation and new ideas that's going to bring the treatments to the kids where they need them. It's important for research as well. What's happened to this point is that all clinical psychologists have published their findings in certain clinical psychology journals. And as the providers out there, you've probably read certain journals that are particular to your discipline. And so the knowledge has been siloed, and we're trying research-wise to bring this information together and integrate it so that it has more a more quick impact. Just from a science perspective, again, you probably have a sense of how important interdisciplinary teams are from a clinical treatment perspective. But from a science perspective, it has been documented multiple times now that it takes 20 years to get an evidence-based treatment that we know is effective actually in use in communities. 20 years is too long. And in fact, that's probably why most of our treatments are not in regular use. And part of the reason it takes so long is because we have these siloed research findings, and that we're not working as a group. Another hallmark of this new science is entrepreneurial relationships, and so we're starting to look more at working with businesses, working with industry partners, and building healthcare and mental health care into the fabric of sort of the day-to-day life of people and communities. So for example, I'll talk about this a little bit later, we have a nice relationship now with an industry partner in Kingsport called the Times Digital Media Group. They actually run the internet-based newspaper for a rural community that we work with. And their data allows us to see the internet habits of parents in that community and allows us to think about where we're putting, say, advertisements or notifications or information about mental health care to that community. Similarly, this kind of falls under interdisciplinary teams and entrepreneurial relationships. We have a marketing expert in our research group. Someone to sort of look at mental health care and try to sort of sell it the way you sell, Coca-Cola or, new sneakers or whatever else is being sold out there, to put a mark on our product that looks a little bit more like something people normally see and not something boring or something that some academic person thought of in some psychology department somewhere. And then finally, another big characteristic of dissemination implementation science is this technology. And using technology, I'm going to talk more about technology later, but certainly if you're going to disseminate something these days, you need to be, as evidenced by the format for our talk today, you need to be savvy in terms of technology. So these are the things that are coming down the pipeline. I think will become more and more noticeable to people that are working in the field. And my hope is that you all will become part of the momentum around dissemination and implementation science. It's going to happen for the research that we do to be real. Next slide. So in terms of just trying to be innovative and think about how do we get mental health services to kids, we know that the specialty mental health care model has failed pretty pretty significantly. Now, that isn't to say that traditional mental health or specialty mental health shouldn't be one of the ways, but it clearly can't be the only way, and especially if it's not innovated in and of itself. So I think we need to be thinking about innovations here to traditional mental health, as well as innovations to the way we provide the services in schools or primary care clinics. A very small percentage of the population seeks services in traditional mental health. It's something like 3% of the population. We know that there are many, many, many more people who would benefit from our services. We also know that people don't attend specialty mental health when they're referred. Studies in primary care clinics show that when physicians refer kids to specialty mental health, only about 17 to 40 of those people show up for their first appointment. So we're not doing very well at getting people to come across the street to our clinics. And also we have a lot of data to show that sort of the modal number of specialty mental health visits that people attend is 1. So we're not doing very well in terms of keeping people coming back to these 1-hour visits that we've developed. And again, I talked about how we have this armamentarium of evidence-based treatments. Most of those right now are in the form of these manualized approaches that require, 8 to 10 or more 1-hour traditional kind of 50-minute hour type visits with a mental health provider. And we just know now that that is not what patients, consumers, parents, kids want. They don't really follow through with that model of care. And so looking at alternate settings is one way to think about innovating practice. I'm going to spend a bunch of time, you can go to the next slide, talking about primary care-based work, just because that's what I'm the most familiar with. But really this applies to school-based health care. Really, it's the same thing. If you have a school-based health clinic, you're providing primary care or elements of primary care in the school, and so all of these concepts apply. I've already provided some rationale, and Sherry provided some earlier, basically stating that people aren't showing up for specialty mental health services. Most people, 70%, seek help for behavioral, emotional, developmental concerns in primary care clinics. And some of our data that you saw earlier from Stacy showed that, in our population of 330 some people, all of whom had kids who were pretty significant in terms of psychosocial concerns, 60% had sought specialty mental health, which is great, but many more, 80, 90%, I forget the number, had sought services from their physician. So the primary care setting really does seem like a good spot for sort of just being. The other thing I'd point out is that it's pretty hard to disentangle a lot of what goes on with people medically from their daily life habits, good and bad, as well as kind of how mental health concerns draw out health problems. We know people with chronic health problems have more mental health concerns, and there are a lot of these studies basically showing that it's pretty hard to tease these two things apart. And so why not treat them in a unified approach? Certainly, as Sherry pointed out, this model reduces an awful lot of barriers. And if you have the primary care clinic in the school, you reduce them even more because you don't have as many places to drive, you don't miss as much work, and certainly, and I've worked in primary care clinics my whole career, when the nurse calls a patient to the back to be seen by me, nobody knows the difference, as opposed to parking your car in front of a private practice that everyone in the community knows is a mental health facility or a private psychologist's practice. So the stigma issue can be especially a barrier in rural areas, and we feel like the primary care setting offers the opportunity to reduce that barrier. There's a lot of different models. I'll just speak briefly about the model that I have been following the most closely, and that is population based care model, which really seeks to combine behavioral health and primary care. Well, it seeks to integrate behavioral health into primary care in a way that keeps pace with the population health care model. So much briefer visits with families, much more focused visits, and not doing traditional 50-minute visits. And I'll just say that I've attempted to do more of a co-located model where I was doing traditional practice in a primary care clinic. And in rural areas, and I know this would be true for some urban areas as well, the waiting list that you have is so long. You really, if you're seeing one patient an hour, you're really just tied up for a very long time, and you're not able to see the numbers of patients that the physicians are seeing and referring. I had an 80-patient waiting list for 4 or 5 years in one of the practices many, many years ago when I was working a more traditional model. And so now we try to see patients in exam rooms. We try to see them in 15 to 30-minute visits. We don't necessarily need to see them back. We kind of go on what the patient's needs are, how much distress they're in. It turns out that that patients' distress is a predictor of how much they will seek services in return for follow-up visits. It turns out that if you follow patient improvement, most patients do improve in the first few visits anyway, and so there's really no evidence that more hours of services equals a better outcome. And so I've made a bullet there that as we move forward in this work, we're looking at expanding to school health programs. And so this is just an idea of how setting and manipulate mental health services, the traditional mental health services, to be something different. Many of the families I see know that I'm a behavioral health consultant. They don't necessarily hear that I'm a psychologist when I'm introduced. I'm introduced by their primary care doctor, who often stays in the room for part of my discussion with the family. It's a seamless handoff, and they're able to hear some recommendations from me in the same way that their provider gave them moments ago, and we're also able to coordinate those services. So it's just a different way of providing the service to them that may be more palatable or easy to kind of access and reduce those barriers. Okay, next slide. The other consideration is technology. This is not an alternate setting. This is something that you could overlay. So you could use more technology-based services in the context of doing primary care-based services, or in the context of doing school health clinics, mental health within school health clinics. Technology is just, exploding in terms of its capacity to do more. I could talk about the types that are out there all day, but the big ones are, we have now really sophisticated and inexpensive two-way video conferencing technology. We have smartphones and internet-based programs that allow people to access pretty sophisticated and individualized treatment programs, and those can relay with their medical records so that physicians can keep up with their progress, let's say in a smoking cessation program, or their monitoring of other health behaviors, let's say it's diet, sleep. We also have some really cool remote monitoring devices that are getting less and less expensive and more user-friendly by the day. For example, right now you can purchase a scale that has a wireless capacity in it. You can put it right into your bathroom. It doesn't have to be hooked up to a computer. So you put it where you would use it, and every time you step on that scale, it relays your weight data to a program. That program could be tied into your primary care clinic. Same thing with other aspects of, say, a diabetic regimen, so blood sugar levels, or somebody who's monitoring heart rate or blood pressure. All that stuff is now available in very easy, these kind of gadgets and these kind of wireless, inexpensive digital monitoring programs. There's also a fair number of little gadgets out there that are cheap and easy that you can give to people where it periodically asks them questions that they have to answer, and those answers come back to someone that's monitoring their progress. There's lots of health applications for this, but there are a few researchers looking at monitoring depression this way. And I won't go on and on about how technology reduces barriers. Anybody here who uses online banking or online travel services knows how much easier that is than the old school way. And I'm going to give some examples in just a few minutes. So I think I've covered most of what I wanted to talk about with relating to technology. You can go ahead to the next slide. And so technology has a lot of potential, and recently the National Institutes for Health put out a call for clinical trial planning grants and also clinical trials proposals that would leverage technology to promote better mental health care. And so we put a proposal in, and this is sort of the follow-up project to the study that Dr. Williams was talking about earlier. And I've mentioned some elements of this project as I've been going along, but this project integrates technology, so I'll be talking about how that happened and giving you some examples as we go through here. So basically what we proposed was this links project with a rural community about 60 miles from here. And what we're proposing is that we deliver mental health care to children using a technology-facilitated system. And we proposed 3 different technology based programs. First, a two-way video conferencing system to link the schools, the primary care clinics, and the mental health providers with families. And so I mentioned two-way video conferencing earlier. I think it's important for you to know that there are a number of studies emerging now showing that two-way video conferencing works just as well as face-to-face. And earlier we showed you that parents in our first study were they were the least willing to seek services via telehealth. It was sort of a neutral rating, and they didn't dislike the idea, but they weren't as enthusiastic about video conferencing as the other methods. It turns out that's a pretty standard finding, but programs, demonstration projects, and other projects that have looked at action, including I've studied about 50 or 60 parents that have participated in two-way video conferencing for behavioral health concerns with their children, rate high levels of satisfaction with this service. So I think it's one of those things that once you're in it and you try it and you do it, you see its value and you really like it. You don't think it's a big deal, but thinking about it up front without really knowing what it is or having any exposure to it, people are a little less willing. So we already have a limited two-way video conferencing service to this rural community, and it's serving about 5 to 6 families weekly. What we'd like to do, that's really underutilized, and so the service is there, but it's in a primary care clinic, and it links us to a mental health service to a primary care clinic. Families that come in can be seen by us, but really we would really like to think about how we could add schools in. And to make this happen really right, the way we proposed it was to have access at every teacher's computer, to have access in every exam room so that providers don't have to go far out of their normal routine to kind of get us in there. And that's feedback we're getting from them. We also proposed an internet portal for information exchange. This could certainly happen through electronic medical records as well. We haven't figured out the details here, but the idea is that parents do ratings, teachers do ratings for physicians for ADHD evaluations, or there's information that the mental health provider needs that they don't have access to, but the teacher does. And so this would be a place where that information could be uploaded and available to all the members of a team that are working on a child's care together. And then finally, using social media in creative ways to kind of get the ideas out, to get the knowledge of the services out to families, to post interesting stories about treatments. I guess really in a way we're hoping our marketing guy will help us out here in kind of making the services look and feel different, more palatable, more easy to access, more straightforward. Now, I propose all three of these in our grant, but we are waiting really to hear what the community says. And as I mentioned earlier, bringing the consumer and stakeholder feedback in may change how we offer these or what we offer, if we even offer all three of these. Next slide. That's kind of the basic bare bones kind of design of how we expect to use technology, use schools, use primary care clinics to repackage mental health services. I should mention that the services we want to deliver are evidence-based, but we're also truncating them and making them a little bit shorter and a little bit more accessible. I see a question that just came through about when the family has, who pays for student services when the family has no insurance or is underinsured and can't pay their deductible. I think that billing issues are huge, and I think as we move forward with this program, you know, sustainability was a big piece of our grant. We have to look at, well, is fee-for-service what's going to pay for these services? I think that right now that's what's happening in our healthcare system, and so we are going to be thinking about, well, what will fee-for-service pay for, and how can it support all of the elements of this or some of the elements of this program? But I think the answer to that question is really, well, we're hoping that the healthcare system is changing so that there's going to be a different way in which we're reimbursed for services. So it's not a fee-for-service mechanism, and there aren't as many families that are walking around without insurance. And healthcare providers it is incentivized for them to provide a better quality of care. They actually get paid more when people do well. And I think we're going to see some changes to how we can fund these and also make sure that everybody's getting the services, even those who are underinsured or not insured. One thing I'll say about something like social media or internet portals or even internet-based treatments is that once you develop them, they're inexpensive to push out to the public, and you don't have to have insurance to access them. So they really kind of level the playing field. I mean, you don't have to have money or great insurance to access some of this stuff online. Of course, I think as treatment developers, we all have to be thinking about how to get them to everyone, and not just people who are, say, information technology sophisticated. So I mentioned this three-pronged approach, and I'll just mention that this study also incorporates all the things that I said were kind of hallmarks of D&I research. The interdisciplinary research team I mentioned earlier, we have a guy from communications and marketing, we have a medical anthropologist, we have a public health expert, we have a nurse practitioner, Dr. Williams, and myself are on this team. And then the most important members of the team really we're developing right now are people in the community, a service provider group, a parent group, and people who are working at the system level. We're using a mixed methods approach, so we're not just handing out quantitative surveys. We're also interviewing people one-on-one. We're doing group-based discussions. We're looking at internet use, all those things I mentioned earlier. And the last two bullets I've already covered, so you can go to the next slide. And I think that Dr. Williams was going to maybe sum it up at this point.
Sure. So just to sum up all of the various things that we've talked about today, we brought you from the beginning talking about a wide range of barriers that a lot of parents actually perceive, but not necessarily all parents perceive. And the example there is from our first study on perceived stigma. So there wasn't a huge level or high level of stigma perceived by parents. And coupled with that is that parents have identified an overall willingness to seek services from a variety of locations. But it seems like when you consider the combination of those, that barriers, especially stigma, are limiting service seeking. So it's the fact that parents are willing to seek these services, but when they perceive barriers, they're not able to for whatever reason, or choosing not to. And so I think the innovative strategies that both Sherry and Jody have discussed with you today kind of highlight the fact that if we can involve these innovative either locations for services or multi-pronged strategies that include technology and multiple types of teams, that we can address these barriers, that we can provide service, provide access, and that we can ultimately affect children's mental health. Would you like to add anything else, Jody or Sherry?
I think I've said enough, and I'd like to open it up for questions for a little bit.
Yeah, that sounds great.
Well, I want to say thank you.
Oh, sorry. I just wanted to acknowledge the following individuals.
Okay, well, from the office in Bethesda, Maryland, I want to say very huge thanks to Stacy Williams, Jody Palaha, and Sherry Chandler. We do have a couple of questions, and if you three will stay available, I'd like to try to cover this. I'm curious if depression in children is something that is at an equal or higher rate than the standard public in the Appalachian schools that you're working, and if so, is there any type of training going on for teachers or other school health professionals to identify depressed children?
I'm not personally very familiar with the literature in that area. Some of the biggest studies that have been done in this region of the country have shown no differences in mental health for children in comparison to urban populations. So we know that there's a shortage of providers, and that rural families don't seek services as much as urban counterparts. But we haven't we have not documented that they have kind of commensurate disparities in terms of their outcomes.
Okay. Another area that used to be an issue, and I'm curious as to whether or not it's still being identified, was the term school phobia or school phobic. Is that hitting truancy, or are you seeing that in any of your clinics?
I see it a lot, actually, and I've had 2 or 3 physician groups ask me to speak on that. And really, we call it school refusal. I don't know if there's an official term for it. In some cases, and really it's an interesting problem because it's really all about function. Some kids don't want to go to school because they have a fear of something that's going to happen there. Maybe they've been bullied, or they're not very smart and they struggle, or whatever the reason. Other kids have, kind of more of a generalized anxiety disorder or separation disorder, where they worry about their parents when they're gone, and they worry about all kinds of, they just get a heightened sense of anxiety in the school setting that's not necessarily attributable to any particular stimulus, like a test or a bully. And then there is a third group of kids, and I feel like this is the most common group that I see, that have somehow figured out that if they don't want to go, nobody makes them. And so they just increasingly kind of shape up to greater and greater resistance to attending over time. And they're all kids that don't show up on a regular basis. And I think that is a fairly common, it's not the most common problem, but it's a pretty common problem. I'd say it's in the top 10.
Okay, I think you all received one other question from our attendees, if you can see that.
I think I see it.
Okay.
Do you have services funded by the Mental Health Services Act in your area? Can you speak to some of the services being offered through that funding and how those are working if you have them? I'm not familiar with that funding mechanism, so I can't speak to that, unfortunately.
Okay, we'll carry that forward to the next webinar, part 2. That's
Yep.
okay.
Sure.
Thank the three of you very much, and I want to thank Sylvia Huntley and Dana Cunningham as well from the mental health section for putting this together. And I should state that in addition to this research and this data, the second part is November the 8th, which will move us with Kate Elkington of Columbia University, looking at adolescence and the stigma of seeking services for those who are HIV positive. So a very similar thing in terms of barriers to services and stigma and labeling, etc. That one's 2 to 3:30 on the 8th. We're also doing our second part related to sexuality education standards. We had a good response last week. Part 2 is October 25th, and you can register for all of these on the Asher web page. We also have one November the 15th related to parental engagement, which fits quite a bit with what we've talked about today. And that one is coming from a researcher that we work with at the Center for Disease Control, Shannon Michael, and we're trying to identify how to engage parents in school health promotion. Once again, I want to say thank you and point out that our conference is October 10th through 13th in San Antonio. We're really happy to have sponsorship today and in San Antonio from the National Education Association's Health Information Network. I mentioned at the top of beginning this presentation that we are offering credits. We have test credits related to our own standards for health education specialists. In addition, we have had arrangements with Maryland to have credits for psychologists and social workers. In addition to that, I did forget to say that we've continued to have a great relationship with Pennsylvania, so that most anything we provide at ASHA related to school health receives school nurse credits in the great Commonwealth of Pennsylvania. With that said, I again want to thank Stacy and Jody and Sherry. Very informative stuff. I feel like I've gone home, which I'm doing, by the way, this weekend to see Rhythm and Roots, and I hope you all will hold that weather that you've got now.
We will.
All of us.
Yes, we will.
Thanks so much. Enjoy your work, and we're really appreciative of your efforts for kids in schools. Thank you.
Thank you very much for organizing this.
Yes, thank you.
Thanks, everyone.
Okay.